Allergy and Immunology at Gangara Hospital, Delhi. With great pleasure, I welcome Dr. Neeraj. He is going to talk on anaphylaxis, and his webinar is a favorite topic, and he has written a topic on anaphylaxis, the standard guideline protocol for OPD practice for practicing pediatricians, started by our own national president, Dr. Ramesh Kumar, and also Vinay Saxena. And with great pleasure, I welcome Dr. Neeraj Gupta. I request Dr. Neeraj Gupta to start his talk on anaphylaxis. Dr. Neeraj, please.
Thank you, Dr. Sukumaran, sir. And at the outset, I would like to thank Central IAP and IAP Trivandrum for the very nice initiative and very important initiative, which is much needed in today's era. So without wasting much time, I will start with the topic, which is anaphylaxis. As we all understand that anaphylaxis is defined as the most severe clinical presentation of acute systemic allergic reaction. What it means that from head to toe, it can involve any of the organ system and it can produce the severe form of clinical manifestations from that organ system. So going back to the history, the word anaphylaxis was originally coined as aphylaxis by Dr. Charles Richet in 1902. And what he meant by aphylaxis means that lack of protection. What the lack of protection was that he tried to inject the anemone toxin injection into a dog and tried to immunize him. So after a series of those injections, which the dog initially tolerated, and later on, one injection he didn't tolerate. Then at that time, it was like lack of protection that the dog has not tolerated. He was not getting protected from that injection. And ultimately, the word called aphylaxis was coined. And later on, the name was changed to anaphylaxis by same Dr. Richet because of the euphony of the words. So that's why the anaphylaxis word came into picture. So originally, it meant as an effect which was opposite to prophylaxis. That means whenever a vaccine or immunization is given, it is usually given as a prophylactic purpose. And if that effect is not there, so it was called as anaphylaxis. And because of that, if you just see the progression of anaphylaxis over the last 125 years, with the initial case definition or the initial term coining, the anaphylaxis incidence increased. But when the definitions got more and more refined, and it was actually meant for the adverse effect or the severe adverse effect, then thereafter, the AD incidence started coming down. And then now, over past, you can say like past century, the incidences once again started increasing, especially in past 3 or 4 decades. So current status is the global incidence is 50 to 112 episodes per 100,000 person years. And the lifetime prevalence is 0.3 to 5.1%. In children, it is 1 to 761 episodes per 100,000 person years. And the recurrence rate varying from 26% to 54% during 1.5 to 25 years of follow-up. The mortality per million people per year has been attributed like to the drugs and the food and the venom induced. It is much lesser as compared to any other disease. So the question is that why this incidence is varying so much, like from 50 to 112 or in children from 1 to 761. It is all because there is still no consensus about the definition or the defining criteria of anaphylaxis. Over the time, the anaphylaxis criteria have changed a lot. Just to see that what were the definitions which were used in last decade, if you see the World Allergy Organization in 2011, and now you see the WHO in 2019. So there is a lot of changes which have happened. Initially, it started from serious life-threatening condition. Then thereafter, it has now moved towards a severe allergic manifestation. Initially, there was just a blanket statement which was given. No organ dysfunction was defined, nothing was defined. Then later on, people started coming in, some definitions started even including organ dysfunctions, skin involvement, respiratory involvement, cardiovascular involvement, and all those. So because of the change in the definition, the incidence in the various papers have been defined later. So the latest consensus is that one of the two criteria need to be met. One is the acute onset of an illness, which should happen acutely. That means within minutes to several hours, with the involvement of the skin or the mucosal tissue. That could be in the form of some generalized hives, pruritus, swollen lips, tongue, or uvula, as well as there has to be one other organ which needs to be involved. That other organ could be either the compromise or the respiratory compromise. in the form of dyspnea, wheeze, stridor, or reduced expected growth, or it could be the circulation, which is affected. Yeah, well, the second organ could be the circulation or the cardiovascular system, which can be affected, leading to hypertension or other end organ dysfunctions like the syncope or the incontinence. Or the third organ could be the gastrointestinal manifestations. In the gastrointestinal manifestations, severe crampy abdominal pain or repetitive vomiting. And that too, especially after exposure to a non-food allergen, which is important. What it meant, that means the first criteria is the skin manifestations plus any of the other three organ dysfunctions, and it has to be acute in onset, then it will be called as anaphylaxis. Or in 10 to 20% of the cases, if the skin manifestation is absent, then even a single organ dysfunction with an acute onset after a highly probable or a non-allergen exposure within an acute duration, that is minute to several hours, then also it will be called as anaphylaxis. That means what I want to say that anaphylaxis need not to have skin manifestations in 10 to 20% of the cases. So in which condition, any of the either the cardiovascular system like the sudden onset hypertension, or the respiratory system in the form of bronchospasm or laryngeal involvement or stridor, if that is present, that is enough to label it as anaphylaxis. I will just take you a little bit through the cases. So the first case, 18-month baby came for routine immunization. 1 hour post-vaccination developed generalized skin rashes, marked irritability, and fast breathing. Child peripheries portaled cool. So if you just see, the child came for vaccination. Within the time period of 1 hour, generalized skin rashes, skin involvement is there. Irritability, that means central nervous system, probably some less perfusion which is happening. Fast breathing, that means respiratory system is compromised, tachypnea is there, and then cardiovascular system is compromised. So is this anaphylaxis? Yes, it is satisfying the criteria, the first criteria. So yes, it is anaphylaxis. 4-year child with 7 ml of ibogesic plus, 30 minutes later developed severe abdominal pain and breathing difficulty. Yes, it is also satisfying the anaphylaxis criteria. That means the severe abdominal pain and breathing difficulty, though there is no skin involvement. So it is satisfying the second criteria, in which there is no skin involvement, but there is a known trigger. Within a sudden defined time, there is sudden abdominal pain, crampy abdominal pain, and breathing difficulty also seems to be anaphylaxis. The third one, 15-year-old female, known case of groundnut and fish allergy, now came for COVID vaccination. Parents are highly anxious about any possible adverse effects because they have heard somewhere that the COVID vaccination should be cautioned, especially those people who are having food allergy. That is why they. So now after vaccination, she started feeling shortness of breath and tingling sensation in the limbs immediately after vaccination, which was like within few minutes. On examination, her heart rate was normal, saturation was okay, blood pressures are normal, there were no adventitious sounds in the chest. So is this anaphylaxis? It is not classifying any of the criteria, either this or that. So probably this is like a pseudo anaphylaxis. Just see this video carefully. 16-year-old girl presented to us with history of multiple anaphylaxis-like episodes in the past. She has presented almost, I think, at least 20 times to the emergency room, receiving adrenaline injection each and every time. Now with sudden onset breathlessness and abdominal pain. What should we label? By the definition, she is fitting in breathlessness and abdominal pain as anaphylaxis. But when we investigated further, came out to be normal. So she was actually having a behavioral problem, and on deeper interrogation, her mother has been diagnosed recently with breast cancer, and the grandfather has expired. Maternal grandfather has expired because of some carcinoma 2 years back. So she was having a definite mental setback, but she was having these type of problems. So what I want to say that there are both overdiagnosis and underdiagnosis which can happen in anaphylaxis. So clinical features, as you mentioned, the skin symptoms are the commonest, more than 90% of the patients. Skin, oral, throat symptoms are often the first one noted. So that means what I want to say that skin manifestations are the earliest manifestation to come. Then the other manifestations could be respiratory, GI manifestations, or shock. Shock is, you can say, like the least common manifestation, but it can happen. And it alone warrants you that probably there is something urgent which needs to be treated. And signs and symptoms usually happen within 5 to 30 minutes. Anaphylaxis can be immune-mediated, can be non-immune-mediated. In immune-mediated, it could be IG-mediated or non-IG-mediated. So in IG-mediated, there are various culprit agents. Most common is the food. Then there are certain medications. So the items which have been starred, they have more than one mechanism. So one is IG-mediated mechanism, but other parallel mechanisms also exist. So there are certain medications. Then there are certain occupational allergens, radio contrast media, venoms, seminal fluid, aeroallergens, natural rubber latex. So they all can cause IgE mediated anaphylaxis. Then the IgE independent, that means either type 2 or the T cell mediated or other cell mediated actions which are happening by this, like radio contrast media, NSAIDs, dextrons, and biological agents like certain monoclonal antibodies. So they can cause non IgE mediated anaphylaxis. Then there are certain non-immunological mechanisms. That means they directly stimulate the mast cells and release the histamine. That means like the physical factors. These physical factors could be some exercise, cold, heat, or sunlight. They all can cause anaphylaxis type of episodes. Ethanol consumption, that can also cause, and certain medications like opioids, they can directly stimulate the mast cells and ultimately cause anaphylaxis. And then if on deeper interrogation or with the investigations we are unable to detect any cause, then for that particular time we can keep the diagnosis as idiopathic anaphylaxis, and at that time it could be like previously unrecognized allergen or a condition called as a mast cell disorder. Then this is about the routine anaphylaxis. Then the anaphylaxis manifestations can last longer. So there is a term which is called as biphasic anaphylaxis or protracted anaphylaxis. So what is biphasic? As the name suggests, it has two phases. That means the symptoms return back after resolution of the initial symptoms without subsequent allergen exposure. This can happen within 1 to 72 hours, usually within 10 hours. So that is why it is now recommended that whenever a patient presents to us with anaphylaxis, in ideal conditions, ideal scenario, that particular patient should be monitored for 72 hours. If that particular patient is having high risk, then at that time need to be admitted, hospitalized, or if not high risk, then at that time can be monitored at home, but need to be monitored for 72 hours. Up to 20% of the anaphylaxis reactions can be biphasic, and they may require frequent or you can say like periodic epinephrine injections to control initial symptoms. Whereas in protracted anaphylaxis, the initial symptoms, the first episode symptoms, they may be continuous for 24 to 36 hours. What are the common elicitors globally? We have already mentioned certain food items which have been labeled globally like celery, milk, hen's egg, peach, nuts, certain sesame seeds, shellfish, tree nuts, wheat, all these, certain venoms, and then certain drugs which have been labeled as, you can say like the common triggers or the known triggers for anaphylaxis. But for India, especially antibiotics, food allergies, surprisingly, they are not there. I will say that it's not that food allergies are not there. It is because we still don't know about the food allergy spectrum in India. We always consider that probably food allergies are much lesser as compared to Western world because of several reasons. But still, there are a lot more data, a lot more research is needed before we actually label that yes, this much amount of foods are really responsible. But other agents are antibiotics, radio contrast agents, anesthetic agents plus blood products, insulin and growth hormone. They can all cause, you can say like precipitate anaphylaxis. Another term which is called as food-dependent exercise-induced anaphylaxis, which has been reported in certain part of the world, more common in the adolescent females or the adult females. It is triggered by exercise 2 to 4 hours after ingesting offending food. That means the two triggers are required and they are required in sequence. One, the initial one is the food, and later on it has to be exercise. So the implicated foods are the same one which we have just discussed, and there are certain associations, non-associations which have been found, like in asthma, if the patient could be having positive skin prick test to foods, and the mechanism is we have described as a 2 signal which are required. And in the idiopathic anaphylaxis, so it is said that it is usually uncommon in children. That means we need to really interrogate deeply in the history and try to elicit the cause, because uncommon causes are usually very less in children. So when it is labeled as idiopathic, when there is negative skin test, negative dietary history, no associated disease like mastocytosis, no drug history, no other trigger factor is there, and still the signs and symptoms are matching with anaphylaxis. In this condition, the preventive medications are often needed, deaths are rare, and may gradually improve over time. Now the common diagnostic dilemma, that means the differential diagnosis. As we understand that anaphylaxis definition itself requires just certain criteria. That means certain organ dysfunction could be the skin and any of the above, or an acute dysfunction of probably the respiratory system or the cardiovascular system. So any of these conditions, whether an acute episode of asthma, whether syncope, acute anxiety or panic attack, so they all can classify, they all can mimic anaphylaxis, and they can define as a pseudo anaphylaxis in this condition. Like I have just given you the case 4, in which there was more like a in case 3 it was hyperventilation, and in case 4 it was like a psychosomatic episode which was happening. So these all are mimicking anaphylaxis like episode, and we might be probably overdiagnosing anaphylaxis there. What are the factors which affect anaphylaxis? So age-related factors. In infants, especially in infants, it is really difficult to pick up anaphylaxis because they cannot describe their symptoms, and we are really stuck up to the signs only. And in adolescents, young adults, it is like because they are having increased risk-taking behavior. That's why they are more prone towards anaphylaxis. Lady during labor and delivery because of risk from certain medications. Then at that time there are more risk of anaphylaxis, and elderly because there is increased risk of fatality from the medication and the venom triggered anaphylaxis. So these are the age-related factors which are considered to be like a higher risk. Now, there are certain concomitant diseases which also predispose towards, you can say, like more higher chances of anaphylaxis. Could be some rhinitis or eczema, uncontrolled asthma, certain cardiovascular diseases. If there are mast cell disorders which are there, so that recurrent anaphylaxis can happen, or certain psychiatric illnesses and the patient is on certain medications like medications for depression. So these can happen. And then concurrent medications like ethanol, or they are using certain sedatives, antidepressants, or recreational drugs, ACE inhibitors, beta adrenergic blockers, NSAIDs. So they all are more prone towards anaphylaxis. There are certain amplifying factors like exercise, as we have just mentioned. Exercise triggered exercise-induced food triggered anaphylaxis. There are acute infections, especially during the time of cold or fever. Emotional stress that can also, you can say, like precipitate an episode of anaphylaxis. Disruption of routine, like during travel or something. At that time, also it can happen. Like that means stress. And then premenstrual state that can also cause, you can say, like amplify probably the anaphylaxis manifestations. How one should diagnose anaphylaxis? So anaphylaxis diagnosis is usually clinical based upon the criteria which have been mentioned. And why these criteria have changed over time? Because it has been seen that there is a reported underdiagnosis of anaphylaxis. Like this is one case study which says that over 80% of almost 8,000 responders correctly identified anaphylaxis when given a case scenario of a patient with skin involvement. But only about 50-55% recognized anaphylaxis when there was no skin involvement. So there is a general notion. Everybody considers that probably if the skin is involved and other organ is there, then only anaphylaxis can happen. If the skin is normal, anaphylaxis cannot happen. So this is not true. So this is important. So the same manifestations which we have just discussed, the diagnostic anaphylaxis, the criteria could be, we have just mentioned about the skin manifestations and either respiratory compromise or decrease in the blood pressure or the gastrointestinal symptoms, or if we can just narrow down or squeeze down or easy it. So the table says that among the 4 criteria, any 2 criteria, whether it is skin plus any 3 or any 2 criteria, then you can say that it is anaphylaxis or any life-threatening event, even in the absence of skin manifestation after a known allergen exposure, which is important. That alone satisfies anaphylaxis, whether it is involving only respiratory or only cardiovascular. Vasovagal attack, which is like a pseudo anaphylaxis type of thing. So a vasovagal attack usually happens within seconds, and it can happen with some like usually the adolescent age group, pregnancy, dehydration, extreme pain, fear, stress. And at that time, the important thing about this is like both anaphylaxis and vasovagal attack can present with hypotension. But the important differentiating point will be in anaphylaxis, it will be usually tachycardia, which will be associated with hypertension. But in vasovagal attack, either it will be normal pulse rate or it will be bradycardia. So that is an important differential to differentiate between vasovagal attack and anaphylaxis, which is important. Diagnosing anaphylaxis, usually in most of the cases, it is clinical. None of the investigations are needed, warranted. And even if they are required to differentiate it from any of the pseudo anaphylaxis type of condition, they are not readily available. Like if you just want to measure plasma histamine, so the half-life of plasma histamine is somewhere around only half an hour, and it's like after the acute attack of anaphylaxis, and the histamine levels usually get normalized within an hour or so. And you just imagine that if a patient who has got an attack of anaphylaxis, how much time he or she will take to really reach to the ER emergency room. That means that probably the golden hour, the initial first golden hour for sending the histamine levels or for the initial 30 minutes, they've already gone. But the patient is presenting to us. So probably the plasma histamine, you cannot really do practically. And even if in certain circumstances you want to do, because if a child is admitted in the wards and suddenly something happens and you pick it up within minutes and you want to send histamine, so it is not available in India. You need to really send the sample outside, and the sample is costing somewhere around 15,000 rupees. So that is also an important thing, and the levels are available later. They are not available right now. That means you cannot do the management based upon the histamine levels, the acute management. The second test is serum tryptase. So serum tryptase start rising, reaches peak within, you can say, like 60 minutes to 90 minutes of the anaphylaxis episode, and thereafter it start declining, and it is said that within 8 to 10 hours it reaches to the nadir. So what I want to say, that suppose if you are having a patient in which you strongly feel that there could be other causes apart from anaphylaxis, or you want to rule out other causes, or you want to see about the baseline high level of, you can say, like the mast cell activation or mast cell activation syndromes, then at that time the basal tryptase and a follow-up tryptase might be helpful. It is once again available in you can say like outside India, and but you can send the sample from here, and it usually costs around 8,000 to 9,000 Indian rupees, and the results are available within 1 month. That means it is also not helpful for the acute management, but for later on, for, you can say, like for putting a differential diagnosis or for diagnosing or suspecting mast cell disorders, it might be useful. The other, like 24-hour urinary histamine metabolite, they are like very poor sensitivity, and simultaneously they are not available routinely. They are available only for the research purposes. So in nutshell, what I want to say, that the investigations are practically not required, not needed. Even if they are required, they are needed in fraction of cases. Then at that time they are not readily available. So office management. So we definitely require our gadgets. We all understand our gadgets and all these things. Anaphylaxis could be a life-threatening condition. So we definitely require all those life-saving equipments. That could be the endotracheal tubes, oxygen, and everything. In this, you can say, like the COVID era, everybody knows about these life-saving equipments. But the most important thing is injectable epinephrine or the adrenaline, which is 1:1,000 dilution. We are happy that in India we have only one concentration here, which is 1:1,000. So we need not to worry about that which concentration is it. So whatever concentration is available in India, that is the correct concentration, which is 1:1,000 epinephrine. So any suspected anaphylactic reaction, we have to just, you can say, like take care of the ABC or the CAB as per the PALS guideline, call for the help, and immediately give adrenaline. So the first thing will be adrenaline or epinephrine, which has to be given IM, intramuscular. And then you need to proceed further. It could be like the establishing the airway, high flow oxygen, IV fluid challenge, and then other drugs for, you can say, like reducing the chances of biphasic reaction. So what I want to highlight here is that any intravenous anticholinergic or steroids, they are not going to help anything during the acute management. They will be able to help or probably reduce the chances of biphasic reaction or the second reaction, which might happen in 20% of the cases after 6 or 8 hours, but not in the acute management. So the life-threatening problems we have mentioned during the airway, it could be hoarseness or stridor or laryngeal involvement. Breathing, it could be rapid breathing. Circulation, it could be shock. And adrenaline is the life-saving drug, which is the message which I want to give. The doses of adrenaline, what you need to remember, for adults or anyone who is more than 12 years old, 12 years and above, it will be 0.5 ml of the same ampule or the half ampule. Anyone who is in between 6 to 12 years, it is 0.3 ml. 1 to 5 years, it will be 0.15 ml. And less than 1 year, that means less than 10 kg, it will be 0.01 ml per kilo. So means like if somebody is having, you can say, like 5 kg, then 0.05 with a maximum dose of 0.1. So these are the doses of adrenaline. So the best way or site to give adrenaline is intramuscular anterolateral thigh. Another important highlight is that adrenaline ideally has to be given as soon as possible. So it has to be given by the patient himself. Whenever he experiences that, okay, probably he is going to feel the next episode of anaphylactic symptoms. So the adrenaline is meant that he should be able to give before the life-threatening condition happens. He should be able to give by himself. So it has to be given IM anterolateral thigh, or the second best choices could be IM deltoid, or then the other are the less preferable sites could be subcutaneous or the intravascular one. These are less preferable. Intravascular has to be given by a person who is trained, especially in the life-saving measures, and because it can cause fatal arrhythmia, so need to be very careful. Anaphylaxis in the ear, this is another case study which suggests that when there was a retrospective chart review was done in 21 North American emergency departments. And a random sample of 678 charts of patients presenting with anaphylaxis due to suspected food was taken. So what they saw that it was including almost 3/4 have received antihistamines, 50% have received steroids, 33% have received some sort of nebulizers or so, and only 16% have received epinephrine, despite the case definition which was fitting in anaphylaxis. And this is happening in the most developed world where all the facilities are available. So you can just imagine that what will be happening in our subcontinent, where probably we are still lacking with the knowledge about the anaphylaxis criteria and simultaneously with the infrastructure of epinephrine availability. The factors which are affecting the prognosis are the poor prognosis will be like if the symptoms are happening early, if the symptoms lasting longer or the treatment is initiated longer, if something is injected, then at that time the chances of anaphylaxis are more. It is poor prognosis, like a venom injection or so, or a drug which is reaching through the IV route. So there are more poor prognosis, more fatal chances are there. Whereas something which is taken for the oral one, then at that time it will be like less fatal chances are there. Then if the patient is already using beta-adrenergic blockers or presence of underlying disease, then definitely there are poor prognostic manifestations. And who should be admitted? If a patient at presentation is having cardiovascular compromise, tachycardia or hypertension. So tachycardia is the first sign of cardiovascular compromise, even if a patient is presenting with a normal blood pressure. Stridor, wheeze, tachypnea, respiratory compromise need to be admitted. No question that he can go home after 4 hours. No. Saturation, less than 95% in room air, need to be admitted. History of protracted anaphylaxis, need to be admitted. That means prolonged anaphylaxis, going on, need to be admitted. Any comorbidity like known case of asthma, arrhythmia, systemic mastocytosis need to be admitted. Or it is likely that you will not be able to follow, or the patient will not be able to get immediate help if needed over the next 72 hours, need to be admitted at that particular time for at least 72 hours for observation. This is the chart, which is like, first of all, the initial management is obviously ABC, and you try for the supine position, but there are certain conditions, like suppose if a patient who is having increased respiratory distress and he cannot lie supine or it is worsening, then at that time you can probably allow sitting, or during pregnancy you might allow sitting, but otherwise preferably supine position. Then there are oxygen, adrenaline we have just mentioned. You can repeat adrenaline every 5 to 10 minutes, and then within 1 to 5 minutes, then you can probably start with the IV access and initial fluid bolus. Then over next 5 minutes, if the child is still not responding, you definitely can repeat the adrenaline injection, and you can start with the nebulized epinephrine, or poor perfusion, you can give the second bolus if the patient is, and alert the ICU people. If still the patient is not responding, then probably definitely it is the time that you need to give the third dose and start on an IV epinephrine infusion and transfer the patient to the pediatric ICU or the tertiary care center for the further management. In refractory cases, or in patients who have already received some beta-adrenergic blockers, then at that time the glucagon might be helpful. Once you decide to discharge the patient either from the emergency room or after the hospitalization, the home action plan will be that in case of hives or itching, that will be the earliest sign. But you need to tell them that it might not happen in probably 1 or 2 times out of 10. Then epinephrine auto-injectors need to be provided. We will be discussing about the availability and all those issues, but epinephrine auto-injectors need to be provided or advised to them. In the absence of that, then we need to probably tell them that how they can use the locally available epinephrine and inject it. And the education, which is the most important thing. Early recognition, epinephrine administration, and approach to nearby healthcare facility and trigger awareness. They all need to be told during the home action plan. The long-term management, that once you have discharged, we have already discussed about the auto-injectors, about the anaphylaxis plan or the emergency anaphylaxis plan. Medical indications, we have already given them in writing. And then thereafter, once everything is done, then thereafter, they need to follow up with an allergy specialist, try to identify the trigger, because we need to prevent the recurrence. So they need to try to identify the trigger by various tests which are available, and allergen avoidance and a possible immunotherapy if indicated, then at that time these will be warranted. So we all understand about anaphylaxis till this time, but there are certain still unmet needs till today. So what are the unmet needs? One is poor recognition and delayed diagnosis. We all understand why. Because of the changing criteria, because of the lack of knowledge in the healthcare workers. So we need to improve this. Lack of universal severity scoring system. We just mentioned that it is like the severe acute allergic manifestation. But is there any severity scoring system? No, it is not there. So anaphylaxis grading has also been given by WHO as per the 5 grades, and they themselves are saying that it is having, you can say, like the varied systems are used in different places. So it is required that a universal scoring system should be there so that everybody should be on the same page. Knowledge gap about the causative factors. The causative factors, we still don't know that which are these causative factors. We never try to dig up in the history. Even the parents are not aware, or the physician is not aware, or the tests are not available. Then there is no diagnostic or predictive test. You cannot predict after an episode of anaphylaxis, you cannot predict that who is going to have a repeat episode, or the high risk groups who are going to have an anaphylactic type of episode. You cannot predict because there are lack of tests. There is remote availability of tryptase estimation, as we have discussed, that if you want to just label, you can say like measure tryptase and to see that what is happening, tryptase is not easily available, and lack of epinephrine auto-injectors, which are not available in India. We all understand this. It's high time to sensitize emergency care physicians, standardized guidelines for diagnosis and management, feasible diagnostic test to be provided, and procure or manufacture epinephrine auto-injectors. Educate at under and postgraduate students, and promote research and data collection. I am very happy and thankful to Central IAP, especially Dr. Ramesh Kumar and team, that they have taken this initiative and they have released this anaphylaxis guideline as one of their module. And I would like to request them to, you can say like, do rest of the other points or take care of the other points also, so that we should be able to mention. Being optimistic. So this is my suggestion. So what we can do is like insulin pen. So we can probably make a indigenous EpiPen, which is like an insulin pen. And as we understand that we are mainly dealing with the pediatric age group. So in the pediatric age group, the doses are different. So we can always tell that which dose that particular patient is required, and only one single pen, a universal pen, which suffice the dose. You just dial the dose and then tell them that, okay, you need to dial and then inject it. So which is important. So insulin like pen might be important, might be useful, which should be cost effective. Then the second thing is the fear of injecting. Even one of the studies says that if a patient who is having EpiPen with them or epinephrine injections with them, and during the time of acute anaphylaxis episode, still less than a quarter of the patient have injected the epinephrine because of the fear of injection. They have not injected. Despite knowing that this seems to be anaphylaxis, despite having EpiPen, they have not injected because of fear of injection. So this is a sublingual epinephrine tablet, which is phase 1 trial have already started. So this is the latest news from December 2021. The phase 1 trial have already started, and we are hopeful that within few years, we should be able to get this sublingual epinephrine tablet, which might be used during the case of emergencies, like we used some NTG tablets in myocardial infarctions or so. And then the third thing is the anti-IgE molecule. So they might be used. There is some research which is going on. They might be used during the time of protracted anaphylaxis or to prevent the recurrent anaphylaxis. So just to take home messages that anaphylaxis management is all A. Means always administer adrenaline, anterolateral thigh IM with adequate dose, as we have mentioned. We need to be agile. We need to be acting swiftly and fast, and to manage anaphylaxis. We need to suspect anaphylaxis early, give adrenaline, and call for help. With this, I would like to stop here. Thank you very much.
Thank you, Dr. Neeraj Gupta, for an excellent presentation of this topic. And it was highlighted the diagnostic criteria for anaphylaxis, and also he has highlighted the treatment and has highlighted the importance of adrenaline. The treatment of choice should be again adrenaline and adrenaline only, and it should be given intramuscularly. But what I have seen is that people are afraid to give adrenaline. They will go for adrenaline, they will give adrenaline, they will give hydrocortisone, etc. Steroids, but they will not give adrenaline. As he has shown me a study in US also, in more than 15% of cases, adrenaline is given only in 10% of cases. So thank you once again for the excellent presentation. And I am also very happy that the international figure and immunology, Dr. Devardhan is also here. He has gone to this talk, and I'm very happy that Dr. P.K. Devardhan has given the answers for most of the queries. Again, but again, you will take up the questions in the chat box. Thank you, Dr. Vedandam, for participating in this. Then we have some of the questions. There's one question.
Thank you. Thank you very much. I don't want to interrupt, but great presentation. Very useful talk. Thank you, sir.
Just Dr. Vedandam, sir, just give your opinion also. Have a comment also, since you are here.
Sorry.
You can have your comments. Just have some comments on the talk of Neeraj Gupta. Comments.
I think excellent presentation. The most important thing is having high awareness, catch it early. And I just wanted to stress that it is purely a clinical diagnosis. Unless you have high index of suspicion, you will miss it, especially in pediatric age group. And you can have anaphylaxis at any age, and a 2-year-old will not complain to you. So your acuity, how watchful you are, is more important in catching anaphylaxis early. The earlier you catch, the better the prognosis and better the response. So overall, very, very nice presentation and a very important topic, not just for allergy people or for pediatricians, for every physicians, including general public. Anaphylaxis is a very important topic because it can occur anywhere, anytime. So epinephrine is the hallmark of acute treatment right now. And thank you, Dr. Neeraj. Thank you, IAP, for arranging such a basic, most important talk on allergy. Thank you, sir.
Thank you. Thank you.
Thank you, Dr. Vedandam. Now, few questions are there is one question is on why it is given IM and not subcutaneous or intravenous.
Right, sir. So it is given intramuscular, especially in the anterior lateral part of thigh. Reason behind, because that particular area is the most vascular area, and it you can say like easily absorbed, and it gets like a depot. So even means like it will be easily available in the body system by that particular area. But suppose if someone gives intravenous, then at that time it directly reaches to heart within you can say like arm brain circulation time. And that arm brain circulation time is like 8 to 10 seconds. So it can be, you can say like causing fatal arrhythmias. So that is why it should not be given IV at that particular time. And another important thing is that IV is only recommended when there is cardiovascular resuscitation is required, because at that time we definitely know that heart is not beating or heart is beating very slow, and we need to really push the heart. But here in the anaphylaxis, the criteria themselves are like, you can say like a general criteria. So it is possible that we are treating more no anaphylaxis rather than actual anaphylaxis with adrenaline. So to be on the safe side, it is better to give IM adrenaline, especially in the anterior lateral part of thigh, rather than IV.
Okay, one more question is that can the nurse give adrenaline in the emergency?
Sorry, sir.
Without the presence of a doctor.
Sorry, sir.
Can the nurse give the? Can the nurse in the emergency room give injection adrenaline without the presence of a doctor? Understood.
Sorry, sir. The question is that can we use adrenaline without the presence of a doctor?
I will repeat the question. Can the nurse give adrenaline by themselves in an emergency room? Can the nurse?
Yes. So I will try to rephrase the question like this: that should the nurse give the adrenaline by themselves without the presence of the doctor? I will say yes. Now the question is, can the nurse give? So that will come to the legal actions. So that will be the legal authorities who need to take the action, and they should be allowing, because when we are giving adrenaline auto-injector even to the patient who is even not qualified as compared to a nurse to give at home, why nurse can't give even in the ER? She should be able to, because adrenaline has to be given as soon as possible. If somebody is able to, you can say like pinpoint those particular signs, as Dr. Vedanta mentioned rightly earlier. Yeah. So they should be given as soon as possible, not to wait for the doctor.
Can I comment?
Yes, please, sir.
Okay.
Adrenaline is like CPR. CPR can be administered by anyone. It's a life-saving procedure. So it should be taught not only to the nurses, but even to the family members, to the patient herself. So we even go to the schools, teach them, because anaphylaxis can occur anywhere. especially at school, is not uncommon because they due to accidental ingestion or whatever exposure. So we teach the school nurses, the teachers, how to administer epinephrine. So it is a universal treatment that need to be taught.
Okay, thank you, sir. Then regarding investigations, you said no investigations are required for diagnosis of anaphylaxis.
Yes,
But
majority
there's
of
a
the
question.
majority of the time there is no need for investigations. Majority of the time it's a clinical diagnosis. If you want to diagnose, if you want to confirm it, you cannot do skin testing right away. You have to wait for 3 weeks because most of the mast cells have depleted of their granules and histamine because of the massive release. So if you want to do skin testing, wait 3 weeks before you do skin testing, which is quite useful, but immunocap can be done because it is measuring free IgE floating, and that is useful. But the history is very, very important here. And so immediately the tryptase is also a good test, but it is not going to give you result right away. It will take you several days before the results come. So it is, again, that's why it is very important. It's a clinical decision. Say, for example, it is not anaphylaxis and you have administered epinephrine twice, patient recovers, you are still all right, because treating with epinephrine unnecessarily is never a mistake, but withholding epinephrine is a major mistake.
Sir, I would like to share one experience from my side. So I used to think the same way around 3-4 years back, and I used to be afraid that what should I teach my parents or the patients about epinephrine injection. So what I started doing, this is I'm telling you about around 4 years back or so. So what I started doing, that I started giving a patient in the outpatient department, not in the ER, in the outpatient department, applying the pulse oximeter, gave epinephrine, told them how to give it. And then what I saw, that nothing happened. Everybody was absolutely okay, no drop in the saturation, no problem in the heart rate, no problem in the blood pressure, but their fear goes away. And now, whenever a patient is coming to me, I am teaching them, giving them the epinephrine. Okay, take this. I'm talking about outpatient department, not the inpatient. Outpatient with a history of anaphylaxis, not anaphylaxis right now. I am asking them to buy epinephrine. I am asking them to break the ampule by themselves so that they should learn. Fill up the syringe, how much I am guiding them. They are injecting in front of me in the anterolateral part of thigh, and they're absolutely okay. They are walking away to their home because nothing happens giving unnecessary extra epinephrine in the IM as compared with holding epinephrine when it is truly desired.
Okay, that's it.
Very practical, very good. I had a patient like that. I had a patient, adult patient with idiopathic anaphylaxis. He traveled by train from Bangalore to Calcutta. So like, I don't know, maybe 24 hours. And he had 3 episodes during that period. And we had given him the crude method of giving epinephrine, where you fill it up in a tuberculin syringe, 0.3 cc, and put it in a spectacle box, cover it up. And we had given 5 of those pre-filled syringes. He used it very successfully and was very thankful. So you could do it for anybody until officially it comes out in India, auto-injector epinephrine. You can do with the pre-filled syringes, put it in a spectacle box, give it. And Dr. Neeraj, everybody knows about all this. And the reason spectacle box is you should not expose it to sunlight.
Sir, Sukumaran sir, thank you, sir. Sir, actually we have one more talk, so can you just give a concluding remarks and find a...
Thank you, Dr. Sudhi. Since we are running short, this session and right of this session, and the key message is that anaphylaxis should be suspected clinically. No investigations are required. On the treatment of choice, should be adrenaline only, injection adrenaline only. People should be available, or as Dr. Bhavana has said, you can keep an injection of adrenaline in a spectacle, and it can be given to a patient at the time of anaphylaxis. So the only drug is adrenaline and adrenaline only. Thank you, Dr. Sudhi and Dr. Rukmini, for giving this opportunity, and thank Dr. Neeraj for the excellent presentation. And I also thank Dr. P.K. Radhanam sir for also joining us for this question and answer session. Thank you very much.
Thank you, Dr. Neeraj, for that excellent and informative talk, and thank you, Dr. Sukumaran sir, for chairing the session. I'm very much delighted to see Dr. Vedansan sir by surprise, because he was one of my teachers in DA course in CMC. Great to see you, Vedansan sir. Now we move on to the next session, that is the State President Action Plan on Childhood Nutrition. Now I hand over the mic to our President, Dr. Rukmini Madam.
Evening. Before going to the next session on nutrition, let me thank Vedantan sir, who is my teacher in DAA. Thank you, sir, very much for attending this session, commenting. Now to the next session, nutrition. First, nutrition, first 1,000 days. That's the topic, and it's a part of ECDN. Around 250 children, 250 million children in world is not developing according to their potential to grow. That is, they are not developing as per their genetic potential. So UNICEF has started this program of ECDN, which includes physical development and neurodevelopment, but it's not neurodevelopment alone. Physical development, nutrition, good health, safety, security, and early learning opportunities. So it's a concept of encouraging a well-being or a well child. So this topic we have chosen because of this importance. Now let me introduce Dr. Somashekhar, who is a chairperson for this topic. Dr. Somashekhar is from Chennai. He was a past president, IAP Tamil Nadu 2019. He was an EB member of CIAP 2021, and he was vice president, South Zone interim CIAP 2021. And now he is working in Sri Balaji Medical College and Hospital, Chennai. He's a good friend of mine. We do have a common factor, like where he is working now, I was a faculty before. He's now the steering committee member of ECDN, and he is also the coordinator of ECDN program, and he has conducted a TOT for ECDN in Chennai. Thank you. Now handing over the mic to Dr. Somashekhar sir.
Thank you very much, my dear Rukmini Madam, the alumni of SPM. Respected our ever dynamic and vibrant President, Dr. Ramesh Kumar ji, in absentia, and our dynamic taskmaster, the Honorary Secretary General, Dr. Vinit Saxena ji, and the President of IAP Kerala, Dr. Jayakumar sir, and Jani, and the immediate past President, Dr. my friend TPJ, who mentioned as we were classmates in the EMD in ICH, and also my friend, the President 2020, Narayan, with another alumni of ICH, and the most important, that is the Trivandrum branch of IAP, which I also feel that it's my hometown branch. Whenever I share a session or be part of the IAP Kerala, I feel some connection is there, some umbilical cord connection, I feel in that sense. And thank you, Madam, for inviting me for this wonderful presidential action plan. Of course, the thought for all of us today. And at this juncture, I also thank the Secretary of the IAP Trivandrum branch, Dr. Sibi and the Andrew, and the immediate past president, my best friend and the teacher of teacher and the author of several books, Dr. Santosh Kumar Shah and Bennett Zaila. And my dear EB colleagues, Dr. Riaz, Nanda, and Jose. And if I don't mention our mentor, who's been shaping all our brains, our past national president, Dr. P. Sukumaran sir. And if I fail in my duty again, if I don't mention our nutrition staff, that is the Florence Nightingale of Nutrition, Professor Dr. K. Elizabeth Madam, who has been behind the show for giving all the guidance and support to conduct this. And I could also see my friend Dr. Guna Singh and many more. If I don't mention any of the names, please pardon. And the topic given today to chair is the 1,000 days, and the speaker is none other than Gopika Sekhar. I think there is some connection because Sekhar Square. I think she is going to rock today. The 1,000 days concept. The most important factor which I'd like to tell you all that the breastfeeding rate, however, we say that 99% of institutional delivery is happening. I think it has nevertheless increased more than 50% in initiation. If you take, for example, the important, the statistics, that is the exclusive breastfeeding. And if you consider the next most important part in the nutrition, because the growth faltering can occur as early as 6 to 9 months. The growth, that is where the minimum acceptable diet, which is going down from 21.8% to 12.5, 12.1%, almost half. So where are our children? 1 out of 8 children goes to, without food, hunger. So that is what I think we'll have to all think and redefine the SDG goals. And however many times we listen to 1000 days concept, I think we used to learn many things. And the next 30 to 40 minutes, I could see initially there are only 50 who are logged in. Now it has multiplied 3 times more. I think I request the IAP, Trivandrum and the Kerala to revise the time, shift the time to 7:30 to 8 so that we can have many, I think, luminaries as well as the delegates will often to listen to this presidential action plan. And without much wasting time to the academic section, I think over to Dr. Gupta. I request once again, Dr. Madam, because I haven't received the CV, I request Madam to introduce the speaker, who is a senior consultant of the Anaphylaxis Hospital and a very passionate teacher, Dr. Gopika. Over to Rukmini Madam to take over and conduct the proceedings. Thank you, Madam.
Dr. Gopika Shekhar is a senior consultant pediatrician in Anantapuri Hospitals and Research Institute, Trivandrum. She is a postgraduate from our own medical college, that is SATH Trivandrum. She is social pediatrics. She is interested and she's doing some research work in nocturnal enuresis and behavioral therapy for that. Now I invite Dr. Gopika for the presentation.
Thank you, ma'am, for your kind words. First of all, I'll share my screen. Is it visible?
Yes, yes.
And audible also. I'm audible. Respected teachers, senior colleagues, and my fellow IAPians, at the onset, I would like to thank the Trivandrum IAP office bearers for giving me this opportunity. I would also like to extend my thanks to Gunashekaran sir, Somashekaran sir, for inviting and chairing this session. And I am extremely grateful to Elizabeth ma'am for guiding me through this topic. So after the very informative and excellent talk on anaphylaxis, you can all sit back and relax. There is nothing new in this, as sir said, there is nothing new in the nutrition in the first 1000 days of life, but on time and then we should always learn to reinforce it and percolate this idea among all the healthcare workers and also the caregivers. So what is this first 1000 days? Actually, the period starts from the period of conception of pregnancy to the first 2 years of it. Actually, in 2012, UNICEF India conceived this idea, and they thought that if we provide the optimum nutrition and care for our children during these 1000 days, they will grow. They can grow. They can develop their full potential, and that will pave a solid platform for their future generation. So, and the government of India, under the RBSK and NHM, adopted this in 2018, and they put forward the journey of the 1000 days to percolate this idea among the health workers, the ASHA, Anganwadi workers, and also the parents and caregivers. So why is this 1000 days important? So it is providing us a great window of opportunity. Why? Because at this time, as we all know, every cell in our body is undergoing a critical period of nutritional programming. So it provides us immense scope for primordial prevention of many non-communicable diseases like diabetes and hypertension in the adults. And as you know, at 2 years of age, the child will be having 20% of the adult weight, 50% of the adult height. So this, it is a period of rapid physical growth. So if we provide them with the right nutrition during this 1,000 days, we can prevent the malnutrition and thus break the intergenerational cycle of malnutrition in India. And 75% of the brain development is completed by 2 years of age. So the glial cells divide, the neurons divide, and at every second, 700 new connections are made in the first 2 years. So if we provide them a good stimulation, a supportive and tender loving environment with the proper stimulation, they can also develop their full potential, brain potential, and have a good learning capacities and learning skills, and develop lay a healthy foundation for their future development. Then what about immunity? These 2 years, it also provides the basis of immunity, especially gut immunity. The colonization of the gut flora by the type of delivery we conduct, and also the colostrum we give, that matures, the gut immunity matures during these 2 years, and along with the breastfeeding and the adequate complementary foods. And moreover, the digestive system also undergoes maturation, the absorptive capacity increases, and many metabolic organs like the kidney, liver, everything matures during this first 2 years. So you all know this 1,000 days window is a great opportunity. So if we give them the right nutrition during this period, we can pave a solid platform for their future development. So my topic, I will be just going through the what are the trends, troubling trends of the maternal nutrition and the infant nutrition statistics during these 1,000 days, as well as what are the essential nutrients required in pregnancy, along with the breastfeeding, what all said and done, how much is, as I said, how much percentage is we are sticking to exclusive breastfeeding, and also the complementary feeding bottleneck. What are we facing in the complementary feeding? What is happening in the when we fall back on complementary feeding techniques? So the statistics troubling trends in the National Family Health Survey 5 says that even though we are saying that Kerala is has very less IMR and infant mortality rate and neonatal mortality rate, only 67% of our pregnant females consumed iron folic acid for more than 180 days. That is from 4th month till throughout pregnancy. And the national statistics is very poor. It is 26%. And even in Kerala, 31.4% of our pregnant females are anemic. And the national stands at 52.2%. And our 30.9% of our females, that is above 15 years and are hypertensive and on drugs. And 24.8% of our females are above 15 years who are on drugs for diabetes. And this year, the 2 new indices were also added on to the National Family Health Survey, that is females who consume tobacco and alcohol. That comes to about 2.2% of in females in Kerala, and 0.2% of females consume alcohol. So how can we advise our girls? How do they plan pregnancy? So you should always plan pregnancy. That is, before pregnancy, we have to start, as you all know, periconceptionally itself, we have to start folic acid to prevent the neural tube defects 3 months before planning and the first 3 months of pregnancy. And you should advise them the healthy food habits. That is, always never skip breakfast, always eat healthy snacks, don't eat more of trans fat and junk foods, and never skip meals. And always stay hydrated. That is, drink at least 10 to 12 glasses of water. And do mild exercises like yoga, meditation, get good sleep, take the necessary vaccines, and protect yourself from infections. And always avoid tobacco and alcohol, because that will do great harm to your fetus. And manage stress both at workplace and at home. So we have to inculcate in them the fact that the right nutrition they are taking has a lasting impact on their baby. That is, They should take more of cereals and millets. And the second, this thing in the pyramid comes the vegetables and the fruits. That is, they have to take more vegetables and fruits, milk and milk products, along with the pulses, and the fats and oils at the top, a very little of fats and sugars. So, and of which fats, they should never take trans fat. They should always depend on vegetable oils, rice bran oil, which contains omega fatty acids, that is very good for the fetal brain. So these are the essential nutrients for pregnancy: iron, folic acid, iodine, vitamin B12, calcium, and omega fatty acids, omega-3 fatty acids. So folic acid, even when consumed from the diet, you have to give it 400 microgram throughout pregnancy, before pregnancy also, and after 4 months, along with iron and folic acid tablets. Iodine, you should take at least 2 spoons of iodized salt per day, and care should be taken that you sprinkle the salt only after cooking. The full cooking is over, because iodine vaporizes away. The vitamin B12, it is strictly deficient in vegetarians. So vegetarians should take special precaution to eat more of milk, drink milk, soya milk, and eat more peanuts. Iron, although we get from the diet, we should take iron and folic acid tablets starting from the 4th month, each tablet containing 100 milligram elemental iron and 500 microgram folic acid throughout pregnancy and lactation. Similarly, vitamin D from milk, almonds, and omega-3 fatty acids from mustard oil and rice bran oil. And the weight gain, as you all know, it is different for each depending upon the pre-pregnancy BMI. It will be different for each female, and that is should be done. They should gain it accordingly. So now we have advised the mother. We have heard over the first 70 days, and we are getting an adequate gestational age, healthy baby. Now what happens? Where are our infant nutritional statistics standing? How can we overcome the breastfeeding hurdles? So when we compare the nutritional status of our under 5 anemic children, we see that it is NFHS 5 shows a rise. It is 67.5% compared to the 4 statistics. And in Kerala, the statistics, we are very worried, because the trend is that it has increased from 35.7 to 39.4%. And the stunting and wasting, we should be ashamed because of the trend. See, it has increased from 19.7 to 23.4, and underweight children from 16.1 to 19.7, and the overweight 3.4 to 4. So we should focus more on the nutritional status of our under 5 children from time on. And the Comprehensive National Nutrition Survey 2016-18 also shows that 35% of our children are underweight and stunted at the age of 5 years. And as you see, the main stunting faltering occurs at the age of 2 years, that is 24 months. And here also there is a peak at the age of when they shift from breastfeeding to complementary feeding. So another key findings in the Comprehensive National Nutrition Survey is that only 57% of our children, breastfeeding is initiated within 1 hour of birth. And only 58% are exclusively breastfed for 6 months. Although 83% children continue breastfeeding till 1 year, only 53% of infants are given the complementary feeding at 6 months of age in the right manner, right frequency, and the right food groups. So how can we overcome all this? That is, breastfeeding should be promoted as the gold standard feeding option. And the colostrum the idea should be imbibed in the colostrum is the baby's first vaccine. And for all normal newborns, skin-to-skin contact should be initiated in 5 minutes of birth, so that they will initiate breastfeeding in the first golden hour itself. The newborn should be kept warm by promoting the kangaroo mother care. And the mother and the family members we should teach them, the babies, how to feed the babies on cues. So these are the hunger cues. When the baby stirs at the mouth opening and the turning of head, the baby is saying, I am hungry. And the next, the baby will stretch and show yawning physical movements and hand to mouth. Says, I am really hungry. With these two, this thing, early cues and mid cues, we should put the baby to breast. But once the baby is angry, crying, agitated, we should pacify her and then start feeding. And the most important doubt every mother has is my milk okay for the baby? So you should tell the mother on the first day, the size of the baby's stomach is only that of a cherry or even a grape. And your 1 teaspoon colostrum you give him, that is more than enough. And the baby will have only 1 or 2 wet diapers per day in the first 2 days. Next, when the baby is 3 to 4 days old, the baby's stomach size will be about only 3 to 4 size of a walnut, and only 3 to 4 teaspoons of colostrum you get is more than enough. And only at the age of 10 days or 7 to 10 days and 1 month, the baby's size will be adequate to receive 30 to 45 ml of the milk you produce. So your milk is always sufficient from the first day of delivery. So how can we reinforce in the mothers and the family members the importance of breastfeeding? It is through the baby-friendly hospital initiative. Every hospital should have a written hospital policy promoting breastfeeding. And all the staff, not only the health workers, the cleaning staff, and all the other paramedical staff, they should be competent to help the mother to breastfeed her baby. And even in the antenatal period, the mother should be counseled regarding the breastfeeding options, whether there is any flat nipple, retracted nipple, inverted nipple. And during postnatal care, during the postnatal period, when the mother is having pain also, we should attend to her and see that her baby she is feeding her baby from always. That is, if she is having severe pain, we can help her. We can, the latch score recently developed, we can daily monitor the latch score, and we can make sure that she's at the end comfortably able to feed her baby by herself. We should support the mothers and the family members in breastfeeding the baby, like looking into what are the problems she's facing, is with the any nipple crack or any injury to the nipple, or is the mother milk insufficient, or is there any medical problem for the baby? All these should be attended to, and all her doubts we should listen carefully, and we should be responsible. And we can also seek the help of lactation counselors for supporting the mother in breastfeeding. We should always practice rooming. That is, the mother and the baby should always be kept in a single room. And we should teach the mother and the family members the cues of feeding. That is, we should encourage them that to responsibly feed the baby by feeding on baby cues. And always avoid bottles, teats, pacifiers, etc. And most important is all post-discharge. We should tell the mother to continue breastfeeding and always keep in touch. And if in the PHCs and all, we can seek the help of lactation counseling units in the community to help her to continue breastfeeding and exclusive breastfeeding till 6 months of age. So always we should take each opportunity we get whenever they come for vaccination or any health visit to reinforce the importance of breastfeeding in them. And once they start going to work, we can always prepare them beforehand how to express breast milk, store it and give it, so that our babies will be healthy with the breast milk alone. So now, so we have overcome the second hurdle, that is breastfeeding. Our baby is born a healthy baby. The baby is on exclusive breast milk for the first 6 months. Okay, now we are thinking of starting complementary feeding. Here also we see that only 53% infants are started, complementary feeding is introduced between 6 to 8 months. And 44% of breastfed children are fed the minimum number of times recommended. That is, either the feeding time is inadequate, or the frequency is inadequate, or the food group is not the right choice. So we have to advise them. That is, there are 7 food groups are recommended for the 6 to 23-month-old children. And we have to choose always 4 or more food groups from this as complementary feeds. It includes the fruits, vegetables, the cereal, grains, roots, legumes, and milk and egg. So complementary food at the first stage, it is always puree form. That is, you have to cook it, mix it, and then strain it so that it will be in the puree form. And you can, the consistency is important, the number of feeds is important, the quantity is important. You start with a take a 250, ask them to, in a 250 ml cup. You start with, in the first 6 to 8 months, 1/4 to half a cup. And first start with 1 or 2 teaspoons, a single food at a time. Do not introduce too many foods. And slowly you increase it to 1/4 and slowly to half a cup. Then the next 9 to 11 months, it should be always in the form of a lumpy foods. That is, you need not strain it. You can just mix it with the hand or fork. And here you can add combinations also. And here the quantity should be 1/2 to 3/4 of a cup. And the frequency should be 3 to 4 times with one snack in between. And in the 12 to 23 months, when the child is having family pot feeding, you can introduce finger foods, and you can always give textured food so that the baby likes to chew away. Chewing and munching is more important at this age group. So one thing we have to be careful is the energy density of complementary feeds. You know, breast milk, the energy is 0.7 kilocalories per ml. And what happens in the complementary feeding, when we introduce complementary foods, the baby is more active than the 6-month-old. So the energy density should be more, 1 kilocalorie per gram. But once you give watery dilute foods, it will come only to 0.3 kilocalories and growth falters at this level. Then the capacity is only 200 ml. So we have to increase the energy density. We have to make it thick and smooth mixtures. For that, we can add oil or ghee, or then we can add jaggery to make the energy dense. And we can also introduce malted or germinated foods. What is malting? Malting is that we can germinate the pulses or cereals, then we can dry it and grind it. And then we can add this to our mixture, our complement feed, so that it will increase the viscosity. Then we can give thick feeds. The consistency, as I said earlier, it should not be too thin, it should be just right so that it will stay in the scope. So we have to see that the foods are given, the right food groups are given, the right quantity is given, the right consistency, and it should also be the energy dense also. And we should cultivate in them good feeding habits. No medias, no mobiles, no TV. We should have no force feeding. That is very important. The baby should decide how much to eat and what to eat. And encourage them self-feeding, even though there will be spillage. The baby, this self-feeding will develop their fine motor skills, and also they will enjoy their meal times. So do not give them excess salt and sugar, because they are super tasters and they need not have too much of salt or sugar. So once said and done, we are educating our parents. They are giving the adequate feeds, but even then, some micronutrients are missing in infant feeding. So we have to supplement vitamin D, 400 international units from birth to 1 year of age. We have to give, according to the Anemia Mukta Bharat, bi-weekly iron. That is a syrup containing 20 milligram iron and 100 microgram folic acid 2 times a week. And from 9 months onwards, we have to start the prophylactic vitamin A drops, and we should practice regular deworming. So once it is very easy to say all this, but what is happening? The Feeding an Infant Toddler study 2016 says by 12 months, 18% of our kids fall short on dietary iron. And by 3 years, many of us, 75% of our kids are consuming too much sodium and too much sweet foods. And by 5 years, 25% of our kids, their daily calories come from snacks. So this data we should rethink that where is our nutrition advice going on? Why are we not able to imbibe in them or make them understand the importance of the right nutrition and the right kind of food that they should practice. So always we should tell them you should include the 7 food groups and make them that the food group should be in rotation, and always encourage that they should have a healthy breakfast even from the preschool ages, preschool time, that when they go to breakfast, they should have a heavy breakfast and a very light dinner. And you should make them learn to read food labels, and you should be a model to them. Do not eat snacks with the junk food snacks in front of them. Do not eat food in front of TV. Then, and you should tell them what are the nutrients that you require more, like vitamins, cereals, pulses, egg, milk, and you have to limit these chocolates, and do not gift them with chocolates and burgers and snacks when they ask for these things. So all said and done, these are the references from which I took this, the practical guide of early child development and nutrition, IYCF guidelines and nutrition first 2 years. But even everything we say, it's very easy in black and white, but very difficult to practice. And so the importance of the nutrition in the first 1000 days should always be reinforced. And we should, as pediatricians, we should take every opportunity to introduce this concept in the parents as well as the caregivers and all the paramedical staff, Anganwadi workers, and educate them about the need for the right nutrition and right stimulation during the first 2 years of life. Thank you.
Thank you very much, madam, for your very extensive and very precise at the same time, to the point, talking right from how important is the 1000 days, what is it for and forever, how is the window of opportunity one should make use of it, and how to break the intergenerational cycle, and right from the programming as in utero and what could be done at the extrauterine environment, starting from the initiation of breastfeeding to exclusive breastfeeding to the bottleneck complementary feeding, which you have touched upon very clearly, and how to start. There is one slide which really appreciated was when you put the salt and you put danger. So now the advice even yesterday in the IICF meeting that we should all disseminate the knowledge that there should not be an added salt and sugar until 1 year of age. That message is also being brought. And the maximum, the cognitive development is kind of achieved. The 75% at the age of 2 years. So how early the stimulation is important as far as the development, both in terms of emotional as well as other, and everything you have put in as a matter of fact for the recommendations with reference to the micronutrients, how much to be given. I think if there are few things in the chat box, can I take up first the chat box question, madam?
Yeah, sir. So a few questions you can take, sir.
Yeah.
Because of the time limitation.
Yeah, we just take 1 or 2 questions, the most important. Yes. One is from Dr. Gupta Anand, that earlier the MUAC was considered as an age-dependent criteria in 6 to 59 years old. But WHO has given part of the arm circumference. So whether the thought should be used or the definite cutoff values are to be used.
പിന്നെ പാനൂരിലൊന്നും ഹോസ്പിറ്റൽ ഇല്ല വേറെ നല്ലൊരു പാനൂര് നഴ്സിംഗ് ഹോം അത്.
Hello.
Yeah, madam.
Hello, sir. Can you hear me, sir?
Yeah, yes, ma'am.
Yeah. Sir, can you? There is some. Hello.
Someone is trying to.
The question was earlier, MUAC was considered as an age-independent criteria. Charts of arm circum. So whether these charts should be used or the definite cutoff values are to be used. I think the definite cutoff values will be used because we can
I request Dr. Zakaria to kindly mute. There is a huge noise coming up. Now the Galaxy is a flip. There is, please kindly unmute.
Hello?
Okay, now we can hear.
So I think it would be better to use the cutoff values. That is MUAC less than 11.5 as SAM and 11.5 to 12.5 as MAM and more than 13.5 as normal. Elizabeth madam, any? Hello?
Elizabeth madam, please, is any clarifications, madam?
There are many compliments for your presentation, madam. Very practical, excellent talk, and
Hello?
you have really message from even Karnataka, Andhra,
Dr. Somashekhar. Dr.
Yes, sir.
Somashekhar.
Yeah.
I am Dr. Gunasingh.
The Galaxy is a flip is.
I think somebody is implementing the advice, I think.
Over to Dr. Gunasingh, sir.
Yeah. So first of all, congratulations to the Dr. Rukmani. I think she said omega-3 fatty acids, we need to use rice bran and mustard oil.
Yes, sir. Yes, sir.
I don't know if everyone started using mustard oil in Kerala, what happened to your coconut oil economy and other thing? I think Kerala people are using lot of sardine fish, that is matti fish, that contains lot of omega-3 fatty acids. I don't know.
Vegetarians, sir. Vegetarians, we can advise rice bran oil and mustard oil, sir.
No, I don't know. We in Tamil Nadu, we never use rice bran or mustard. North Indian people use that. I think locally available oil should be used. That's what I believe. I think you are you using rice bran oil and mustard oil in Kerala?
We are using mustard oil, sir.
No.
I don't know. Okay.
Sir, we can use the oil in rotation, sir.
Yeah. I know it is. It contains a healthy issue. I mean, blended with mustard oil and rice bran is good. But another thing is, you said 9 months onwards, you need to give vitamin A drops. What guidelines does it give? Which organization they advise? WHO or UNICEF, whatever? I don't know. I have never seen that. Even our vitamin A prophylaxis program itself, it is questioned. I don't know that. Another thing is, you said soya bean milk also you mentioned. Did you mention?
Yes, sir. Soya milk is source of vitamin D.
I think that and all. We are not talking to your Arab sheikh to tell. Soya bean milk is so much costly. Whatever available milk, I think they can take. I don't know. It is what guidelines soya bean milk, and it is so costly. I think sometimes I saw.
It was from UNICEF 2012, sir. The first 2 years.
That's why UNICEF, WHO, it's a pseudoscience, I believe. I think we should not carried away by their advertisement.
Okay, sir.
Are we going to tell you take soya bean milk? We are talking to your lower income group, those who are suffering. I think we need to be little careful in advising all those things. Thank you, ma. Sorry.
Okay, sir.
Any clarifications from Somashekhar, sir? Elizabeth, madam.
Hello, I am Dr. Elizabeth here. I think I am very happy that we had the 2 sessions, excellent talk. And regarding the MUAC, mid-upper arm circumference, the previous cutoffs which were there, that is the 11.5, 12.5, 13.5 is not useful on an individual setting. But if you are going to a community and you don't have all the Z score charts and all, we are using that MUAC, and that too, that will pick up the children at risk of dying. If you are going to individually categorize a child, it is better that you go for by the WHO or IAP, the mid upper arm circumference Z score and